Good morning, all. We'll have a short discussion about what are the methods available for the fracture fixation. Before going into the topic, we should know that what is the aim behind the fracture fixation. The first and the most important aim of the fracture fixations are in order to restore the anatomical relationship, absolute or relative stability, preservation of blood supply, early and safe mobilization. So these are the four main aims of the fracture fixation. I'm repeating it once again. To restore the anatomic relationship and to absolute and the relative stability to achieve preservation of blood supply, early and safe mobilization. We'll move into the topic and we'll discuss what are the methods which is available for the fracture fixation. General term, we used to say it's a closed and the open method. The closed method or the nothing but without directly visualizing the fracture fragment, we are going to reduce it. Whereas open method is nothing but the direct visualization of fracture fragment will be present. So there are few direct interdental wiring and there are few indirect interdental wirings and continuous multi-loop wiring, arch bar fixation, circummandibular wiring, and peralveolar wiring. So what is direct wiring and indirect wiring? Direct wiring are nothing but we are going to place directly across the fracture fragment after that exposure. So that we are going to place the wiring across the fracture fragment directly. Whereas indirectly, fixation is nothing but adjacent structures are used as an anchorage to immobilize the fracture fragment. And one should know what is the rigid fixation and the non-rigid fixations. So first I told about the closed reductions and the open reduction, and then direct fixation and indirect fixation, rigid and the non-rigid fixation. Rigid fixation are nothing but the aim of this fixation is nothing applied directly to the bone, which is strong enough to prevent the interfragmentary motions across the fracture fragment when they are actively using the skeletal structure. Just remember, rigid fixation are the one where we are going to apply directly to the bone, which is strong enough to prevent the interfragmentary motion. Whereas there is like non-rigid fixation, so which allows the allows the interfragmentary mobilizations will not be present. So nothing but the non-rigid fixations are the one. There is a mobility of osseous segment during an active use of skeletal structures following the application of internal fixation. So this is the non-rigid fixation. Example for non-rigid fixations are the intraosseous wirings. So remember, in the rigid fixation, we can able to prevent the interfragmentary motion, whereas in non-rigid fixation, we cannot able to prevent the interfragmentary motions. So I'll show the pictorial representation of each wire. It's not, you just remember the picture and the few points about the wires. I will tell you the few points. ASIC wires, this wire is most commonly used in a case of the mandibular fractures. So you can use the anchoring device for the intermaxillary fixation. So just remember, it's used for the intermaxillary fixation. So there should be sufficient number of teeth should be present on either side of the fracture line. So just remember these 2 points. For an ASIC wire, the sufficient amount of the teeth should be present. If there is a fracture which is present in the symphysis region, in order to place the ASIC wire, the sufficient number of teeth has to be present on either side of the fracture line. So just remember this. And another point is that it is used to stabilize the dentoalveolar fracture, as well as it can be used as an anchoring device for IMF, which is nothing but intermaxillary fixation. So it is used to stabilize dentoalveolar fracture and also used as an anchoring device for IMF. And there should be sufficient number of teeth should be present on either side of fracture. So this is a picture which shows the ASIC wiring. So this is nothing but direct dental wiring, which is nothing but Gilmer's wiring. The most common and the simple methods of wiring. So only the firm teeth of maxilla and the mandible will be chosen for this type of a wiring. It is also used for intermaxillary fixation. So just remember, it's also used for the intermaxillary fixation. So the main disadvantage of this wiring is that it may cause extrusion of the teeth whenever the excessive load is applied. So just remember, extrusion of the teeth is one of the complications of the direct dental wiring. but it's most common and the simple methods of used. So it is used for the intermaxillary fixation. So just see that whenever you are placing a wire across each single teeth, whenever you apply an excess amount of the force, there are chances for the extrusion of these teeth can occur. So which is the most important complication. This is a pictorial representation of Risdon wiring, which is commonly used method of horizontal wire fixation. Just remember, it's an horizontal wire fixation. See, it's similar. This is a wiring which is similar to that of an arch bar, so that it can be used as a substitute technique for the arch bar. Remember that it can be used as a substitute technique for the arch bar. Another important point in this Risdon wiring is that in this method, the second molar is usually chosen for anchorage on either side. So just remember, the second molar is usually used as an anchorage and it can be used as a substitute for an arch bar. So sometimes you may get a question, which wiring technique can be used as a substitute for an arch bar? So you have to answer it as Risdon wiring can be used as a substitute technique for arch bar. Coming into the eyelet wiring. So there's a picture which represents the eyelet loop wiring, where the two adjacent teeth has to be used. One or two eyelet wiring has to be used in each quadrant. For example, if you're going to place in a maxilla, you have to use this wiring either in between the molar and premolar, central incisors, and the molar and premolar on other side. So at least 3 eyelet wiring has to be placed in the each arch. It can also be used as instead of an arch bar for the intermaxillary fixation. So just remember the pictures. This is the arch bar, which has been proposed by Erich arch bar, which is most commonly used technique for intermaxillary fixation nowadays. So this arch bar technique, so just remember this is an Erich arch bar and the length of the arch bar is 30 centimeters. So this loop which should always face towards the gingiva. So these were the most important point in this arch bar fixation. But remember, recently we are using the IMF screws and hybrid arch bars. So the difference present between the arch bar and the IMF screw is nothing but, in case of an arch bar, there are chances for damaging the gingiva, because like we are going to place a wire across each teeth. If you place a wire across in each teeth, there are increased chances for damaging the gingiva in that region. To avoid that, nowadays we are using IMF screws, which is nothing but we have to place a screw in the region, particularly either in between central incisor or between the molar and premolar. It's just a screw just placed in between the tooth. It's not an entire arch bar or hybrid arch bar. Hybrid arch bar are nothing but arch bar attached with the screws. Instead of using a wire, you are going to fix the arch bar with the screws. So just remember the two terms. The second is circummandibular wiring, which is most commonly used case of the pediatric patients where there is multiple permanent tooth which is presented inside the bone. So it's like a multiple permanent tooth will be present inside. In order to prevent the damage to that permanent teeth, we'll use this circummandibular wiring for the fixation of the cap splints. Usually for the cap splints or gunning splints fixation, we use this circummandibular wiring. So this is a picture shows that cap splint is fixed using the circummandibular wiring. Circum, which is nothing but along the mandible. So circum, it will enclose the entire mandible. This is the picture. It shows a peralveolar wiring. Peralveolar wiring, just remember, in case of patient is presented with the fracture of edentulous mandible or a maxilla, to do IMF, you require gunning splint fabrication. I hope everyone knows the name of gunning splint, which is used for the fixation of edentulous fracture. In case of gunning splint, for a mandibular gunning splint, we can fix it with the circummandibular wiring. But in case of maxilla, to fix the gunning splint, maxillary dentures, example is a maxillary dentures, you are going to use this peralveolar wiring. So just remember, I have told you there are wirings, SIG wiring. Most important point is that sufficient amount of teeth should be present on either side of fracture line, and it is used for fixation of dentoalveolar fracture. Direct interdental wiring, it's most commonly used for IMF. Complication is that extrusion of the teeth. Residence can be used as a substitute for the arch bar. Eyelet is used most commonly, and it's one of the most commonly used method for intermaxillary fixations. And one of the important point is that 2 to 3 eyelet wiring should be placed in the each arch. Arch bar is given by Erich, and the length of the arch bar is 30 centimeter. Disadvantages is periodontitis. To avoid this complication, nowadays we are using the hybrid arch bar and the IMF screws. Circummandibular wiring for the fixation of cap splints or the gunning splint. Paraorbital wiring is also used for fixation of maxillary dentures. Coming into the internal fixations. Just remember the term, as I told, semi-rigid and the rigid fixation. Rigid fixation, as I told you people, rigid fixation are the one which will prevent the interfragmentary motion across the fracture fragment. Whereas semi-rigid or the semi-rigid is also called as a non-rigid or a semi-rigid fixation, which is that it is a form of non-rigid fixation, which is nothing but it is also the form of non-rigid fixation that are strong enough to allow the active use of skeleton during the healing phase, but not of sufficient strength to prevent the interfragmentary mobility. So that is a disadvantages of using a semi-rigid instead of rigid fixation. So we have to see what are all these semi-rigid fixations. Transosseous wiring. The name itself states that it's a wire which is going to transverse the bone. So it's across the bone. Transosseous wiring, non-compression mini plate. Rigid fixation, there are two types, which is compression fixation and the fixation osteogenesis. So compression fixation includes dynamic compression plate. I'm not going in detail about each and everything, so I'll tell you the few important points in each thing. DCP, which is nothing but dynamic compression plate. EDCP, eccentric dynamic compression plate. Lag screw. So fixation osteosynthesis includes locking plate, reconstruction plate, torque, which is nothing but titanium hollow osseointegrated reconstruction plate. Titanium hollow osseointegrated reconstruction plate. There's a picture which shows the transosseous wiring. So the transosseous wiring or the nothing but the wire which is going to cross the bone. So these are the transosseous wiring, which is most commonly used for the fixation of mid-phase fracture. So we'll discuss about these wiring in detail whenever we are going to discuss the leaf-hole fracture, because these wirings are most commonly used for the fixation of mid-phase fracture. As I told, there is a mid-phase fracture, so that's nothing but the fracture of leaf-hole 1, 2, 3. So in such condition, these types of transosseous wiring will be used, which includes frontal suspension, circumzygomatic, infraorbital, and the piriform aperture suspension wiring. So this is also the another picture which shows the frontal suspension wiring, lateral suspension wiring, piriform suspension wiring, and the circumzygomatic suspension wiring. So this is the non-compression mini plate, which is nowadays we are using these types of the fixations where a single mini plate will be placed across the fracture lines. So just remember the picture and then importance of it. There's a compression fixation where we have seen there are two types of compression fixations, which includes dynamic compression plate and eccentric dynamic compression plate. Just remember, it is a type of rigid fixation, comes under the compression fixation. And then the basic principle behind the dynamic compression plate is a spherical guiding principle. Remember the three term, it's a type of rigid fixation, comes under compression. Compression, the name itself states that it's going to compress between the fracture fragment. By compressing it, is going to reduce the fracture fragment. So this is based on the principle of spherical guiding principle. Remember, spherical guiding principle. Usually, this plate will be placed across the compression zone. I hope you people remember there are two types of zone present in the mandible. Tension zone along the alveolar ridge and a compression zone along the inferior border of the mandible. So this plate is usually placed along the compression zone. So and there is another, as I told, eccentric dynamic compression plate, which is similar to that of the dynamic compression plate, but only like disadvantage of using the eccentric dynamic compression plating system is that one should require the extraoral fixation. It means that extraoral incision has to be required. Whenever we are going to place an extraoral incision, there are chances of creating a scar. So to avoid that, we are not using nowadays. Lag screw, it's also a type of compression osteosynthesis, and it's a bicortical fixation. We are using only mini plate, which is a monocortical fixation. Remember, lag screw, this is a lag screw. It's a bicortical fixation where the buccal and the lingual cortex can be engaged together. So there's a picture which shows the bicortical fixation of the lag screw where it engages the buccal and the lingual cortex and it compresses the fracture fragment. And these are all the monocortical screws monocortical screws, lax screw. This is one picture shows us the mini plate fixation, monocortical screws, and the lax screws. So this is the recent advantages of rigid fixations, a locking plate, where one of the advantages of using the locking plate is that the screw will get locked with the plate itself. So just see this. This is a normal plate, normal screws, and this is a locking plate. In a locking plate, you can able to appreciate there is a place which is present in between the plate as well as the bone. So the plate will not compress the bone so that the vascularity will be maintained. Whereas we are using a plate where it's a mini plate without a locking type, where the plate will compress the bone, will causes the compress and the vascularize will get compromised. Whereas locking plate, the screw will get locked with the plate and it allows the adequate blood supply to take place. So that is a difference between these two. Just remember, in locking plate, you will have a space between the plate and the bone, so the vascularity can be maintained. This is the reconstruction plate. Everyone knows that's the long plate, which is most commonly used after the segmental resection or in case of the complex fracture in order to maintain the continuity of inferior border of the mandible. So this is the TORP plate, which is nothing but titanium hollow osseo integrated reconstruction plate. The only difference is between this TORP and then reconstruction plate is that you can able to appreciate there is this minute holes which is present along the screws. Whereas in reconstruction plate, we will not have these types of holes along the screws. Whenever you have a hole, so this hole will also allow the osseo integration, which is nothing but it allow the bone to grow inside this hole so that the further fixation will be there comparatively to that of reconstruction plate. So osseointegration will be more compared to that of reconstruction plate. That is the difference between the TORP and in case of a reconstruction plate. So coming into the final slide of this topic is a resorbable plate. I hope you people will remember this. This is a recent advantages in cases of a maxillofacial surgery. Nowadays, we are using this resorbable plate, especially the resorbable plate are used for the pediatric patient and the patient who are present with the skull bone fractures. So one of the disadvantages of the resorbable plate are it cannot able to sustain the sufficient amount of the force because the force will not be, it will not be able to bear the sufficient force. Whereas these plates can be used, as I mentioned, it can be used for the pediatric patients. And this resorbable plate will be a lactate, L-lactate. I'm mentioning the few names of it. L-lactate, DL-lactate, polyglycolate, trimethylene carbonate, which is nothing but TMC. So remember, polyglycolic, polygalactite, polyglycolate, L-lactate, and DL-lactate, and TMC, trimethylene, which is nothing but trimethylene carbonate. It has a degradation characteristics and it will take a year for this resorbable plate to completely disintegrate and it will excrete as a hydrogen and the carbon dioxide. So just remember the name of these plate and the use of these plates. So as I told, it may undergo hydrolysis phase and the metabolic phase. Hydrolysis phase, water molecules are inserted into the long macromolecules cleaving into the shorter polymer chains. Or metabolic phase, the breakdown products of glycolic and lactic acids are metabolized by the liver into carbon dioxide and the urine. As I told, these resorbable plate undergo disintegrations in the body, either by hydrolytic phase, just remember either hydrolytic phase or metabolic phase. In case of hydrolytic phase, the water molecule will be inserted into the long macromolecule and convert them into short polymer chain. Just remember, hydrolytic phase. Metabolic phase, which is nothing but these products, as I told, lactic acid, polyglycolic acid, so D-lactate, L-lactate, they will get metabolized in the liver into carbon dioxide, which will excreted through respiration, into water, which will be excreted through urine. So remember, these are all the resorbable plate. So PLA, sometimes used to say that PLLA, which is nothing but polylactic acid, lactolate, DL-lactate, or maybe a polygalactide, so polyglycolide. So these are all the most commonly used resorbable plate. So if you come across these names, just tick that they are all resorbable plate, get degraded in the body either by the hydrolytic phase or by metabolic phase. If it is metabolic phase, it will be metabolized into carbon dioxide and the water. Carbon dioxide will be excreted either through the respirations and the water will be excreted through urine. So these are all the various methods are available for the fixation of fracture in case of oral and the maxillofacial surgery. So coming into the external fixators. Nowadays we have seen that internal fixators. Now we'll see about the external fixators. These are all the external fixators, either a K-pin. So these are all a K-pin, which is most commonly used for condylar fixation or in mid-face fixations. And you can able to see this hollow frame, which is most commonly used in case of mid-face fracture fixation. Remember, hollow frame is an external fixator used for mid-face fixations. Box frames, you can able to see the patients present with the LE4-2 fracture. Box frames can be used. So these are, and then it's leave-in frames, and this is a single picture which shows the all the external fixators like frontozygomatic fixators. This is a leave-in frame. This is a cap splint fixators. This is external mandibular fixators. And these are all the parts of the fixators, universal joint and the bone pins. So just remember, few extra fixators. It has been used previously, but nowadays it's not most commonly used because this is the one where the fracture fragment cannot be visualized directly. And then, so it's most commonly like patient has to wear it. So it can be, it's obviously aesthetic effect and the patient cannot be able to bear it. So either fixators are K-pins used for mandibular fixation or mid-face fixation, hollow frame, leave-in frame, box frames. So these are all the available external fixators. So just remember, closed, open reduction, rigid, non-rigid fixations, direct wiring, indirect wiring, semi-rigid fixations, and what are all the rigid fixation, compression and fixation osteosynthesis, and what plate will come under compression and what plate will come under fixation. So the plate are dynamic compression plate, eccentric dynamic compression plate, black screw will come under compression. So the name itself states that it will compress the fracture fragments, whereas fixation osteosynthesis includes recon plate and the titanium hollow osseointegrated plate. So just remember the names of that plate and the pictures of that plate. And then external fixators, hollow frame, POP, and box frame, and the leave-in frame. Thank you.